Welcome to AETCM, the emergency medicine channel. Today we're discussing about a elderly female patient who presented here with complaints of heaviness of head since past 2 days. So a 76-year-old female came to your ear that day morning with complaints of heaviness of head since the past 2 days. On my initial 10-second assessment, patient was conscious or not going to make amends. So under the primary survey, her primary survey was actually almost within normal limits. Her airway was patent, breathing was normal, and respiratory rate is 18 per minute, and SpO2 was 98% in room air. Circulatory part, her heart rate was 77 per minute and blood pressure was 160 by 90. GCS, she had a full score of GCS and pupils were equally reactive on both sides with 2.5 mm. And pain score, she complained of like a vague heaviness like symptom and pain was only 2 to 3 out of 10. And we offered her a IV paracetamol and she was actually willing to take it, so we give her 1 gram IV paracetamol. And she was febrile and GRB's check was 91 milligram per deciliter. So we went to the secondary survey with this IV paracetamol ongoing. Patient presented with complaints of some heaviness of head since past 2 days and also associated with some nausea and some abdominal bloating and fullness like sensation. And also she had some burning sensation in the epigastrium.
What are the conditions he can get heaviness of head or headache associated with abdominal problem?
Like acute gastritis,
Headache?
GRD.
Dehydration. Okay. Gastroenteritis induced dehydration. Okay.
GRD like
Why headache?
I think,
A classical example is migraine.
migraine.
Most of the migraine, if you ask the history, most of them will have headache. They have abdominal pain. Okay. Sometimes they can have abdominal pain alone, abdominal discomfort alone without headache. Esophageal migraine. Okay. So migraine is one condition which can present like all these symptoms: vomiting, abdominal discomfort. Okay. So we have to keep it in mind. Elderly individual can have migraine.
Okay. So there was history basically with heaviness of head and some nausea, abdominal bloating sensation, and burning sensation was also there. And there was no history of any like vomiting, LOC or anything. There's no recent history of any fever, cough, breathlessness or anything. No loose stools or being noted. And although one previous history is basically she had a history of diagnosed hypopituitarism. A lot of years back, about more than 5 years back, she was diagnosed to have a small pituitary. And secondary to that, actually, they were started on a tablet hydrocortisone, which she was taking 10 milligram in the morning and 5 milligram in the afternoon. But since past 2 years, actually, she stopped the evening dose. But currently, she's taking only 10 milligram in the morning. That's only one.
So if you are giving for replacement therapy, it has to be steroid has to be given in 2 doses, morning and evening. If you are giving as an anti-inflammatory dose, then one time dose is enough.
There was some extra history actually we got from her. So there's no history of any drug allergy or anything. She's a non-case of diabetes, hypertension, and also this hypopituitarism and also hypothyroidism, for which she is taking 75 microgram per oral OD.
Okay.
And so previous history, she's also has a non-case of PVOD. That's an additional history. That's the. And then there's no any other significant events contributing to the symptoms. The only history is some vague and disturbing pain which progressed over the next day. So she came to the hospital. But even after giving pain relief, actually she was not, her symptoms were not relieved. So we went ahead with the CT brain scan was taken, but it was again normal. It was not showing any intracranial or extraaxial bleed was noted. And so again she came back. So we went to the clinical examination. Her actually there was no paralictus, cyanosis, clubbing or edema or infernopathy. Other systemic examinations were also within normal limits. There was no focal deficits or anything. Her pupils were equally reactive. Her chest was clear, bilateral equilaterally. Cardiovascular and GIT was also, abdomen was also not soft, non-tender. There was no tenderness or anything in the epigastrium also noted. ECG was also taken. It was not showing any acute ST changes. So in view of this vague complaints, actually we had offered for admission and she was admitted.
Why you are told about STT changes? What do you
want? Actually, especially in elderly female patients, they can have vague symptoms presenting with acute MI.
Okay.
So we offered it, took a ECG and it was not showing acute changes. Anyway, she was actually taking clopidogrel in the as a regular medication, even though there was no clear history of any previous CAD. So we offered admission and she was willing to get admitted, so we admitted the patient. So initial lab investigation said I was not showing any elevated inflammatory markers. Count was 7,000 and CRP was 3.2, but electrolyte sodium came to be 170.
117.
117. There was one this thing. Then also thyroid function test was done. It was showing
When the patient on thyroid hormone replacement, what thyroid function test you can do?
TSH.
TSH. What is the TSH value?
TSH came to be low in this patient. 0.15 was it? 0.15.
Okay.
And T4 came to be 0.81.
Okay.
Both were low.
Both were low.
Even though she was taking her regular medications,
So we don't know whether it is primary hypothyroidism or secondary due to pituitary deficiency. That gland is, you told it is small. Okay. In that case, that means central hypothyroidism. What is the ideal test for follow-up? There TSH will not be elevated. Even if you are giving suboptimal dose, TSH will not be elevated because TSH is released from there. There you have to see the TRH. Okay. Not only TRH, you have to see the thyroid hormones. Whereas in normal hypothyroidism, we don't do thyroid hormone levels because we most of the time it will be normal or above normal. There TSH will increase when there is suboptimal dose. Here TSH is not released or a suboptimal release. So TSH cannot be done there. You have to go for thyroid hormone levels.
So T4 also came to be low, like 0.81.
Okay. So when we don't know the value of like what type of hypothyroidism it is, we can, if the patient is having weakness and all, we can slightly increase the dose. Okay.
So this patient was admitted.
What is the heart rate?
Heart rate is 77.
Okay, so we can easily increase the dose. If suppose it is tachycardia and all, we will have difficulty in increasing. We can easily increase the dose to next level. So 25 microgram can be increased and 100 microgram we can make. You can see whether the patient improves with that.
Because this patient actually considering her like low sodium and symptoms like a weak headache and nausea and all that, we initially started with a IV correction of sodium also. We started with 10 ml per hour infusion.
What are the investigation you done if there is suppose you get a case with hyponatremia?
Hyponatremia, actually we have to send for serum osmolality levels to
What
check.
is the osmolality here?
270.
Is it normal or high?
It's low.
So it's a true hyponatremia.
True hyponatremia.
Okay, then
272 was the osmolality.
Then urine
Urine osmolality is 205.
that is low. Urine sodium?
Urine sodium is 68.1.
That is high. So patient is losing sodium through the kidneys.
From her medications, we saw that actually she was taking aqueous side. This is hydrochlorothiazide.
Okay.
12.5 mg.
Okay, that can produce renal loss.
There was one drug she was taking regularly for hypertension. So on admission, we stopped that drug, and since considering her symptomatic like symptoms like headache and nausea, we started on one.
So can we tell it is SIADH here? Urine sodium is more than 40.
It's drug induced can be one reason.
So you have to think that two possibilities. One is the patient is having hypothyroidism. So we cannot brand it as hypothyroidism means it may not be controlled now. We don't know. Then the drug what she is taking. So SIADH is the features suggestive of SIADH, but it cannot be SIADH.
Extra this thing.
Okay, we have to rule out all these things. Then nothing is there. Only we can call it as SIADH.
So considering her drug history and all, we just gave one correction for hyponatremia.
How do you correct it?
We started with this thing. 10 ml per hour infusion was started.
Which one? 3% saline.
3% saline.
How much that contains sodium? What is the sodium deficit in this patient?
It comes
118. So in a day we can correct up to 6 to 8 milliequivalents.
So how to calculate the total deficit has to be calculated.
0.6 into the correction which is required should be taken.
0.6 of your body weight.
Body weight. 0.6
into
body
the
weight.
correction maybe you are telling 8 or 10. So 8 into that much. Around 500 milliequivalents may come. Okay, 400 to 500. You have to ideally calculate and correct it. Okay, then.
And so actually also we ordered to send for a morning cortisol sample.
That's okay. That each bottle contains how much? 51 milliequivalents it contains. So if you want to correct around 500 milliequivalents, how many bottles you have to give?
10 bottles.
10 bottles. How do you correct it? So you are starting now. You are starting for 110, no? 110
170.
170. 117. So you are starting now 10 ml per hour. When will you check sodium level?
After 6
After
hours.
6
After
hours.
6 hours you check. In 24 hours maximum correction will be?
6 to 8 can be there. If we are already calculating the dose required, that means if it is coming as 10 bottles, then we can divide that. Total it will be 100 ml. So
Okay, when we are calculating it on basis of some lab investigation. If it is overcorrecting, patient can go to demyelination. So it is better to see the next day's value and or every 6 hour value, and according to that you can go. Whatever given in books, you are totally calculating the amount, you are starting. But if in between, if you don't see the sodium levels, sometimes this patient can go to higher level. Okay, so should be very careful. We are seeing many patients with pontine myelinolysis. Okay.
So actually, we ordered for patient was admitted and repeat sodium the next day was only 127.
So that means around 10 is corrected. So no need to correct further on the day. Then next day you can correct. And more than 127, better not to correct. If the patient is okay, we can start oral feeds. Okay.
And also, she gave a previous history of some similar episode like about 3-4 years back. At that time, actually, she again presented with hyponatremia, then low thyroid levels, and at that time, they found to have low cortisol secondary to hypopituitarism, and she was on IV steroids at that time. So this time also the clinical presentation was similar. So considering her accurate presentation, we just gave one 25 milligram of hydrocortisone was given that day night.
Okay. So in a patient who is having hypocortisolism, which is documented, he come to emergency room. What should be your action? Whatever may be the condition you admitted for, surgery, trauma, pregnancy, or something like this. What is your action?
We have to increase the dose.
Just increase the dose. Just give additional dose of drug. Now we are giving IV. We don't know about the patient's condition. Patient has to improve. We can investigate afterwards, but give a steroid and close that chapter. Otherwise, the patient may go to hypotension, shock afterwards. Okay, so immediately increase the patient requirement. The steroid level has to be increased. Okay.
And also following admission, we asked sent for a serum cortisol level, which is going to be
ideally cortisol has to be taken before steroids, not after steroids. If you want to know exactly what is the levels, then before steroids it has to be drawn.
But this patient we sent for a morning sample.
Okay, that is a wrong way of doing it. 8 AM cortisol is for diagnosing hypocortisolism, not for follow-up. Follow-up we have to take random, means whenever you are seeing the patient, draw it. Okay.
So the report we got was 3.3.
Okay.
And so
that is low.
Low.
What do you think?
It could be secondary to our IV.
So after giving steroids, the central release can come down, reduce the. We don't know exactly what happened to the patient.
But by next day, actually, repeat sodium was 127 and steroids was showing like 3.3. And also that day morning, we increased the thyroxine dose from 75 to 100 microgram.
Okay.
But actually, by her symptoms got improved by next day morning.
Okay.
Even though we start on IV steroids in the evening and also planned to give like TAD 25 milligram, but by morning symptoms improved.
In a patient who is admitted in ICU, acutely like sepsis, shock, or withdrawal like this, TAD or QID? What is the dose of hydrocortisone?
TAD.
Standard textbook says 50 milligram every 6th hourly. Or infusion, continuous infusion. It is in sepsis and all other conditions. But on discharge, it is always BD. So convenient dose are BD. Okay. So maximum either increase it as continue it as an infusion protocol or every 6 hourly, because steroid action will be only for 6 hours. Okay. So anti-inflammatory action prolongs. But adrenal action, it acts only for 6 to 8 hours. So better to give every 6 hours. That's why most of the standard textbook says that 50 milligram every 6th hour. That is the dose.
So her symptoms improved next day morning. So actually, considering that, we changed to oral medication.
Okay.
So since she was actually withdrawn, she stopped her evening medication since past 2 hours. We restarted that. And again, continued to observe for one more day, and symptomatically she was completely better.
What all drugs you restarted?
Mainly hydrocortisone was restarted. Like we started with 10 and 5.
Okay.
10 in the morning and 5 in the night, and also her previous.
If the sodium does not improve, what do you do? even after giving 10 milligram BD. What else you can do? You have to make more salt retention. What you can do? Any other steroid you have to add? Hydrocortisone has to be added in that condition. Here it is okay because hydrocortisone has got some mineralocorticoid action. So it will help you to retain sodium. But if it does not happen, then you have to add hydrocortisone.
Since actually by about 3 days she was completely asymptomatic and symptomatically better, and lab parameters are also okay. So we discharged her with again restarting her oral steroids.
Okay. Now we have to find out why the patient was started on steroids. We have to find out what was the actual thing when they started steroids. Most of the time steroids are started unnecessarily. Okay, here you are telling it is hypopituitarism, but other features has to be there. If it is hypopituitarism, so many other clinical features will be there. Nothing is having, patient does not have anything, and patient had past history of TB. Most of the time what happens is along with TB, physician starts steroids, they will not withdraw it. Patient may continue it for longer time. So it is our duty to find out what is the reason why patient was on steroid, and if possible we have to withdraw from steroids. If the patient is on steroids like this long term, what are the other precautions we have to advise?
Mainly glucose, like
Blood sugar has to be monitored and controlled.
Then cushion like features.
That is obesity. Okay. Then that we cannot prevent because steroids will produce Cushingoid features.
HPA suppression will be there.
And that we are giving steroid for that.
In case of sepsis or trauma.
You have to increase the dose. No, daily what are the ulcer protective drugs? You have to give proton pump inhibitors or ranitidine. Then osteoporosis, you have to give calcium, vitamin D, and alendronate. Then myopathy, some patients with steroids can develop myopathy, but we cannot prevent it. If steroids are required, we have to continue it. Any other prophylaxis recommended nowadays? PCP, pneumococcal pneumocystis cerevisiae. Prophylaxis has to be given for all patients on chronic steroid. Okay. Then?
Okay. So basically, if a patient is coming with a history of hypopituitarism, the thing is actually the pituitary actually secretes a lot of hormones.
Okay.
In that, the main concerning factors is one is thyroid control and second is ACTH, which mainly stimulates the adrenal cortex to release cortisol. So whenever a patient is coming to our ED with complaints of some vague symptoms or even an acute hypertension or something, the first thing is actually we have to rule out any adrenal crisis.
Okay.
Adrenal crisis means basically a sudden drop in this cortisol and not just cortisol, the total hyperfunction of adrenal system can actually cause resistant hypertension, which may not improve with fluids or anatropes, in which the first mainstay treatment will be like IV steroids.
Okay.
And once that is ruled out, then we can go for like detailed clinical examination and then rule out any other secondary causes. So basically, if a patient is having adrenal dysfunction, can be primary or secondary. Primary can be adescence, which will be affecting all the secretions or all the hormones released by the adrenal gland. So adrenal gland mainly has cortex and medulla. Cortex will be having 3 layers. One will be secreting mineralocorticoids like aldosterone, and the second layer will be releasing cortisol, that mainly our steroids, and then the third will be sex hormones. And the medulla will be releasing adrenal, noradrenaline, and some dopamine. So suppose it's a primary adrenal issue, then all the secretions will be reduced. So the patient will be coming with like acute features of low anotropic, low epinephrine and those kind of features. So the patient
mainly hypertension, diarrhea.
And so if that is the condition, we have to think about a cause of primary adrenal insufficiency. But suppose the patient is only showing features of like secondary features like low cortisol level or like in the lab test, or maybe features of low cortisol like
hyponatremia is one of the lab investigation which tell you that cortisol is low.
Cortisol is low. So electrolyte imbalance, then any history of recent weight loss, anorexia, GA symptoms, vomiting, loose stools and everything. We have to think about a secondary suppression. And also if the patient is on chronic steroids and then they are coming with an acute symptoms like that, we can go for a stress dosage. That is actually whatever the patient is taking, which we can give as IV steroids at TID for 1 or 2 days to improve her clinical symptoms, especially if the patient is planned for some surgery or something. So, in a normal patient, about 20 milligram per deciliter is the average cortisol level in the body. It will be more released in the morning time and less in the evening time. But suppose we are sending for a random cortisol level, it is more than 18 milligram per deciliter, we can rule out ACTH deficiency. So which we can rule out any secondary adrenal insufficiency. But if it is lower than 18 and then she is having features, and if there is any related stress related to this event, like any recent history of sepsis, infection or anything, we have to supplement with whichever dose of oral steroids she is taking, we have to give as IV in the initial phase of admission. And once she is stabilized, we can...
So you take immediately when you suspect, you take a sample for cortisol and give steroids, IV steroid. That is the correct way. Okay, don't wait the investigation to follow after steroid.
So once actually her secondary symptoms are reduced, then we can actually again change back to oral and advise to continue.
Okay.
But in this case, actually, patient also had, as I said, actually had a history of TB lymphadenitis in the past. That time, actually, she had taken long-term steroids.
Okay.
And after that, about 6 months later or something, she presented the hospital with complaints of acute onset of giddiness and was found to have hypotension. And this they assumed with some like imaging done showing some pictures of micropituitarism, and they started on continuous steroids. And which she has been taking continuously. So with the current presentation, we are not yet sure whether it is actually an true adrenal insufficiency or maybe like her acute withdrawal maybe have caused the symptoms. So anyway, our post-admission actually electrolyte was corrected. Symptoms were like
potassium is normal.
Potassium was normal.
Okay.
And electrolyte imbalance and everything was corrected, and also for the time being her steroids were again restarted. But anyway, she was advised to follow up on discharge for further like titration of the dosage and like further evaluation.
Okay. Anything else you want to add? Okay. Thank you.
Thanks, sir.